All right, so this is going to be a high yield review of the GI system and nutrition. GI is a huge blueprint on the PANCE, and so we're going to go through this Rosh guide, which is going to take us through very high yield, quick hits through the entire GI system. So let's get started. Here's kind of at a glance of what we're going to cover. And we're going to start off with biliary disorders. So biliary disorders includes acute and chronic cholecystitis, cholangitis, and cholelithiasis. So cholecystitis, this is most often caused by an obstructive gallstone. Remember, acute cholecystitis is that classic right upper quadrant colicky pain after consuming fatty foods. And we often see that gallstones happen in the F, so female, fertile, 40, fair-skinned. So we often see it in those populations more often, but it can happen in pretty much anyone. They also can have some accompanying fever, nausea, and vomiting. On physical exam, we're looking for that positive Murphy sign, which is when you press in the right upper quadrant as you ask the patient to take a deep breath and they stop their breath in because it hurts. And then they can also have a Boas sign, which is increased or altered sensitivity below the right scapula. So kind of in the back area, they get pain there as well. Diagnostic studies, the study of choice for that right upper quadrant pain is going to be a right upper quadrant ultrasound. And that's what we're going to do in the emergency department or wherever they are to assess for cholecystitis and probably cholelithiasis. However, the gold standard for diagnosing cholecystitis is actually a HIDA scan, but we generally don't do a HIDA scan unless we don't see the exact cause or maybe they don't have acute cholecystitis. So HIDA scan can be done to kind of show problems with motility of the gallbladder as well as kind of a more chronic picture. Management is going to be removing the gallbladder via a cholecystectomy. So chronic cholecystitis, we don't see this very often, but the main thing we want to know for this is this calcification of the gallbladder wall. This is also known as a porcelain gallbladder. So it looks like it's like porcelain glass, so it's all around the gallbladder. If we see a porcelain gallbladder, we should think gallbladder carcinoma. This is a much increased risk, and we need to go look for the cancer. Acute cholecystitis. So before we were talking about regular cholecystitis, this is acute cholecystitis. So again, it's going to be some of the same things that we were talking about earlier, but the risk factors are going to be above the age of 40, obese, women, having more than one child, family history, and then they also see it sometimes in rapid weight loss. They're going to have that right upper quadrant pain, plus or minus some nausea, vomiting, maybe fever, and they're going to have a positive Murphy sign, which is that palpation of the gallbladder during inspiration, and the patient stops breathing in and kind of catches their breath when you're pushing in that right upper quadrant area. Diagnosis, again, is going to be made by ultrasound. We can do HIDA scans, but we typically don't do that as first line at all. And sometimes we'll see it incidentally on a CT scan if we're looking for something else. But management is going to be supportive care if it's mild and they don't have high markers or it's not showing complete obstruction or anything like that. And a cholecystectomy is going to be the end game treatment for it. There's also something I want to mention here that they're not mentioning is called biliary colic. So sometimes patients that have gallstones, they can intermittently block the gallbladder. And when that happens, especially after the gallbladder has to work really hard after a meal, they will get the same type of pain that they would with acute cholecystitis, usually about 30 minutes or so after they eat, especially a fatty meal. And this causes that crampy right upper quadrant pain and sometimes some nausea. But the thing that's different about biliary colic is that it resolves, it goes away. So most of the time the stone kind of dislodges and everything kind of calms down, the pain goes away. So a lot of times patients with acute cholecystitis will report having had episodes of that same typical type of pain after eating fatty meals, and that is what's termed biliary colic. All right, now let's look at primary biliary cholangitis. So this is most often caused by T-mediated attack, so it's autoimmune, and they have a slow progressive destruction of the liver. And we often see this in women that have autoimmune conditions, other concomitant autoimmune conditions, usually 40 to 50 years old. And they often present with fatigue, jaundice. They have intense itching throughout their body, right upper quadrant discomfort, and weight loss. And what we'll look for as far as diagnostic studies is going to be an AMA, or an anti-mitochondrial antibody. This will be positive, and we can sometimes get a biopsy of the liver too to help us make the determination. And we'll often see, a slow progressive destruction of the bile ducts, especially the small ones, which is why we get the stagnant bile flow, which causes a pruritus, a fatigue, and all of these other liver enzymes and things will be elevated as well. We like to contrast this with PSC, which is primary sclerosing cholangitis. And with this, the primary sclerosing cholangitis, we usually see this in men with a history of ulcerative colitis. And they often present again with the pruritus, jaundice, fatigue, malaise, and lab evaluation. We usually see a cholestatic pattern, so the bile is not moving, and we see elevation of alk phos, but no positive AMA. Cholangiogram can be done via MRCP or ERCP, and that shows us the sclerosed bile ducts in there. They have an increased risk of cancer, and it's usually associated with ulcerative colitis. So look for that in the vignette as well. All right. Acute cholangitis. So acute cholangitis is when the gallstone blocks the duct, usually the common bile duct. And it's different because cholecystitis, usually the stone is here in the cystic duct or at the neck of the gallbladder. But this is blocking the common bile duct. So it's blocking the passage of bile from the liver and from the gallbladder. And so we see increased symptomatology with this. So it's most commonly seen and caused by cholidocholithiasis, which is a gallstone within the duct, and it leads to a bacterial infection, most often E. coli. And so we're going to see two things. We're going to see either a Charcot's triad or a Reynolds pentad, which is worse. So Charcot's triad is going to be fever, abdominal pain, and jaundice. And make sure you look for this jaundice. Jaundice should not be there if it's just acute cholecystitis. As far as Reynolds pentad, it is those three, the same Charcot's triad, plus confusion and hypotension, which is worse. And the management for this, well, we need to know that it is what it is. So we need to find it. Most often we'll do the right upper quadrant ultrasound first. And then from there, we'll see that there's some inflammation. Maybe we'll see the stone lodged in the CBD. And then we'll probably go ahead and do an ERCP, where we take the scope, we go up into the duct, and we try to remove the stone. And it's diagnostic and therapeutic at the same time. In addition to this, because we have an infection on top of a blockage, we need to give antibiotics for this. This is sometimes also called ascending cholangitis, because the bacteria that are in the small gut here tend to ascend up the ductal system to cause the infection. And here's like a good little drawing of the biliary tree, which you should be familiar with. And don't forget your triad and your pentad. You have to be able to pick out in the vignettes. Cholelithiasis, so it's kind of almost taking a step back, because cholelithiasis are gallstones. It doesn't imply any type of inflammation or infection or anything like that, but this is the precursor to a lot of the things we've already talked about. So gallstones are most commonly comprised of cholesterol. We want to look for the four F's. So female, 40, fat, which is not a nice thing to say, but we're talking about overweight women and that are in their fertile years, okay, and that have had multiparity is an increased risk factor for that as well. So a lot of times these patients will present with intermittent right upper quadrant pain, especially after eating fatty foods like biliary colic. An ultrasound is going to be diagnostic of this. And then if it's just mild, if it's intermittent, it's not constant, and they don't have any signs or symptoms of acute cholecystitis or acute cholidocholithiasis or ascending cholangitis, we can observe them and supply some supportive care, tell them to stay away from fatty foods. And if it becomes persistent or they develop acute cholecystitis, then that's when we need to consider getting a cholecystectomy. Cholidocholithiasis occurs when the stone is lodged in the CBD rather than in the gallbladder and the cystic duct. And this one can cause, again, jaundice and other problems. Okay. Biliary tree anatomy, again, you need to know this, and you need to know the difference between the different locations of stones and what it would cause. So if a stone was in the pancreatic duct, we're going to see gallstone pancreatitis. If we see a stone blocking the common bile duct, this is also known as cholelithiasis, but it can cause an ascending cholangitis. If the stone is in the neck of the gallbladder, in the cystic duct, we're going to see either biliary colic or acute cholecystitis. Okay. And so that's really important to differentiate. If you're having trouble still, I have an online escape room that I'll put the link in the comments down below. You can take a look at that. It helps you kind of walk through the different presentations and the subtle differences between all of these different things, which can look really similar. All right, moving on to colorectal disorders. So there's a lot of different things on here, and I will tell you that this tends to be a little bit on the more graphic type of presentation. So definitely, if you're at Starbucks or in a public place, I'd definitely get in a little corner where other people are not going to be offended by what we show on screen. So let's move on. We're going to start first off with pilonidal disease. So the pilonidal area is at the gluteal cleft, which you can see is at the top of where the two buttock cheeks meet towards the top here. And this area is the area where we will see pilonidal cysts or abscesses. We often see pilonidal disease in men, but it can happen in both men and women, and we see it in less than 40 years old, so younger people. And they'll have this pain over the tailbone area, and it'll be tender, fluctuant, and it's called the sacrococcygeal cleft or gluteal cleft. And management is going to be, if it's acute, if it's painful, if it's red, then we're going to treat it like an abscess. We're going to do incision and drainage, probably place the patient on antibiotics. And the definitive treatment for this is going to be surgical excision of that abnormal pocket. All right, anal fissures. So anal fissures are basically like little paper cuts or cuts around the anus, and they can be very, very painful. Just like, they're small. Paper cuts are small, right? But they hurt a lot and they can bleed. So think of that when you think of anal fissures. Very pesky. They can cause rectal pain, bleeding, and it usually happens right after defecation, especially with straining. And it's most often posterior midline. If we're looking at the anus as like a clock face, it would be kind of with the anterior up above and posterior towards the back. It would be kind of at the posterior midline, so it'd be kind of at 6 o'clock position. So management for this, we're going to use stool softeners. We have some ointments and sitz baths that can help soothe the area and keep it from becoming inflamed. But basically, we need to get the stool soft enough that we're not straining to have it, because the straining itself is what usually precipitates the anal fissures. And if we have anal fissures that are oriented laterally, this should raise concern for some sort of pathology. So lateral pathology would be things like Crohn's disease, other malignancies in those areas. As far as primary, we see local trauma, constipation being really common, and then other things like anal sex and vaginal delivery. Treatment for this is going to be topical nifedipine or nitro, and topical analgesics, stool softeners, sitz baths, and increased fiber in your diet. Fecal impaction. These are always fun. Think of it in your elderly population, especially bedbound, and they're going to have kind of cramping, bloating, inability to pass stool, or they might pass just liquid stool because it can kind of sneak around the big impaction that they have. They also tend to have rectal discomfort. You can even have rectal prolapse because of it. And so the etiology really is a lack of fiber. When they're bedbound, the motility slows down a little bit in the gut. They also might be on chronic medications that can slow their passage, like opioids. Diabetes and hypothyroidism can also contribute. Clinically, they might have some abdominal distension, and when you do a rectal exam, you will feel a hard ball of stool or mass of stool in the rectal sigmoid area. And then the complications can be necrosis. It can perforate even or cause ulcers in the area. And how do we manage it? Well, it's not fun, but it's what we got to do. We do a manual disimpaction. So we usually give the patient some sort of a stool softening enema in that area, or stool softeners orally, and laxatives. And then we go in, we use our finger, and we manually or digitally disimpact that stool. Ultimately, if that doesn't take care of it, they might need to have surgery. Diverticulosis, major difference. We have to differentiate osis from itis. Osis is the presence of diverticula. So diverticula are little outpouchings in the colon wall, most often seen in the sigmoid colon, so distally. The diverticulosis, the disease of diverticulosis, is often asymptomatic, but when it is symptomatic, we tend to see painless hematochezia, and the older we are, the more likely we are to have this. You also see more diverticula in obese, sedentary cigarette smokers with a high diet in red meat and low in fiber. The test of choice for diverticulosis is going to be a colonoscopy. As far as management, there's really not much we do other than try to keep the stool soft, try to keep the patient from straining. There used to be this advice that we would have patients stay away from things like seeds or nuts or things that can get stuck in those diverticular pouches, but that's not thought of as something that we recommend anymore. As far as the most common cause of significant lower GI bleeding, especially in the elderly population. So think about it. Don't blame it on hemorrhoids. It could be diverticula. Okay. Again, it's often asymptomatic, but when it is symptomatic, it's usually painless rectal bleeding. It's bright red blood since it's distal, and we don't want to miss that. It can be all the way from no bleeding at all the way up to bleeding so bad you're hemodynamically unstable from it. Okay. And as far as treatment, supportive care, most bleeding stops spontaneously, but if it's persistent and the patient is symptomatic because of it, we might need to do surgery. Diverticulitis, in contrast, itis meaning inflammation or infection, we often see a triad of left lower quadrant pain, increased leukocytosis or high white cell count, and fever. Okay, so we'll look for that left lower quadrant pain. We'll have fever, changing in bowel habits. We'll often see like alternating bowel habits, as well as nausea and potentially some vomiting. We also can see some guarding and rigidity associated with this, since the diverticulum tend to inflame the peritoneal lining. It can also abscess in that area, depending. So the CT, the test of choice is going to be a CT, usually of the abdomen and pelvis, with IV and oral contrast. And management is going to be antibiotics to treat the infection. If it's complicated or recurrent, we might consider surgical management, especially if there's an abscess in that area that's pretty large. So as you can see here, kind of this graph, we have diverticulosis, which is the overarching disease, and we have 70 to 80% of patients that are asymptomatic. Diverticular bleeding we'll have in about 5 to 15% of our diverticulosis population, and then itis, we have even less, 4% of these patients that they get complicated about 5% of the time, which includes abscesses, obstructions, perforations, and or fistulas. All right. So again, we already went through this: abdominal pain, nausea, vomiting, fever, change in bowel habits, and hematochezia, but it's more rare with itis, more common with osis. CT scan, and then we have to decide if the patient's sick enough to be admitted to the hospital. Sometimes we can treat this outpatient in uncomplicated patients with no major risk factors, and antibiotics is going to be the treatment of choice. Hemorrhoids. So hemorrhoids affect a lot of people in a lot of different ways. There are two different types of hemorrhoids related to the dentate line. Hemorrhoids that are external, which are below the dentate line, are painful. And so we see these significant pain and pruritus. These are the ones that patients can't really sit down because it hurts so much. And a lot of times the pain is due to what we call a thrombosis, where it gets clotted, and this causes pretty significant pain. If we have it early, we have someone that presents pretty early with this thrombosed external hemorrhoid, we can do an excision where we kind of make an elliptical incision around it and we evacuate the thrombosis. If it's an internal hemorrhoid, it shouldn't be painful. It's above the dentate line. There's no nerve innervation beyond the dentate line or above it. And they don't have pain, but often they present with bright red blood. They might have some anal itching or discomfort, and they might even have a protruding hemorrhoid that you can actually see, feel, or touch. And there are grades of internal hemorrhoids that you should be familiar with. Their degrees are 1 through 4, 1 being the least bad and 4 being the worst. Okay. So the first degree internal hemorrhoid would be hemorrhoids that don't protrude through the anus. Second degree would be those that can prolapse, but they reduce spontaneously. So they kind of peek their head out, but they go back in. Third, they peek their head out, but they have to be manually reduced. So they have to push them back up in. And fourth, they poke their head out and they cannot be reduced. And these are prone to strangulation. Now on to ulcerative colitis. So ulcerative colitis is, remember, falling under the IBD umbrella. So inflammatory bowel disease has really two different types. So there's ulcerative colitis and Crohn's disease. So let's talk first about ulcerative colitis. The typical patient is going to be a young person, so 15 to 30 years old at presentation, and they're going to present with this chronic bloody diarrhea along with crampy abdominal pain, and they get a lot of tenesmus, which is like when you have the sensation in the rectal area that you have to have a bowel movement, but nothing comes out. It's kind of like rectal dry heaving. And the diagnostic study of choice is going to be a colonoscopy. A lot of times, when patients are really, really inflamed, we'll get them in the hospital with the thought that it could be IBD. We'll get them on steroids to get it calmed down, and then we'll introduce the colonoscopy. We need to note that this always involves the rectum. And so I kind of think of it as, those carnival games where you hit the little strongman thing and the little thing raises up and it can go a little bit high or it can go all the way up. So I think of ulcerative colitis as that because it always involves the rectum and it can go up a little bit or it can go all the way up and affect the entire colon. And the extent of colon involvement kind of correlates with the severity of the illness. So management, we often think of sulfasalazine or the 5-ASAs as the treatment of choice. Patients can also have total colectomies, which is curative, but that's usually done on down the line after medication fails. Complications of ulcerative colitis, toxic megacolon can happen. It's not common, but it can happen. And we need to understand that these patients have an increased risk of colon cancer just because they have ulcerative colitis. So we usually do screening in these patients 8 to 10 years after they're first diagnosed, even if they're pretty young. And smoking is actually protective in ulcerative colitis, which is kind of funny. I definitely wouldn't recommend that our patients smoke, but just something to know. All right. And so these are some of the things that we said. One thing that we haven't talked about yet is the extraintestinal manifestations. So both ulcerative colitis and Crohn's both have a lot of potential extraintestinal manifestations. Some of them for UC include pyoderma gangrenosum, which Google it. It's a pretty striking rash they can get. Erythema nodosum, which are the hard lesions on the shins and elbow surfaces, extensor surfaces. They can also get ankylosing spondylitis, arthritis, uveitis, liver disease, renal stones, and primary sclerosing cholangitis, which we talked about earlier. Okay. Let's talk about Crohn's disease. So Crohn's disease, in contrast, whereas ulcerative colitis, we saw mostly bloody diarrhea. In Crohn's, we often see more non-bloody, although it can be bloody, chronic diarrhea, abdominal cramping, and often these patients have weight loss and other extraintestinal manifestations. Because Crohn's disease is transmural and mouth to anus, we often see physical exam findings that show that it has gone all the way through the colon wall, like aphthous ulcers, perirectal abscesses, and anorectal fistulas. You can also get a lot of anal fissures. As far as diagnostic studies, we usually work up both Crohn's and ulcerative colitis together. So we'll do some serologic markings, serum ASCA and PANCE, and some other ESR, CRP, non-specific things. And we'll do a colonoscopy, which will reveal skip lesions. Cobblestoning, where it can kind of happen in little patches, and we will see that transmural involvement. Remember, the most common area within the gut that is inflamed or problematic with Crohn's disease is actually the terminal ileum. And if we do a colonoscopy, we can actually get all the way to the cecum, poke our little scope in, and look at the terminal ileum. And that's how we usually make the diagnosis. We can give mesalamines, but we don't see them used nearly as often as we see in the ulcerative colitis population. The treatment for Crohn's is quite extensive and quite complicated. Surgery is not curative because it often inflames the small bowel. Remember, it can affect any part of the GI tract. As far as treatment, you can do the top-down approach or the bottom-up approach, and that's not geography related. It's how bad the symptoms are for the patient. If they're pretty mild, we usually do bottom up, meaning that we start with something mild and kind of progress our way up. If we have a patient that's having pretty severe disease on endoscopy and on symptoms, we tend to hit them hard early and then back off to a comfortable remission. And a lot of times nowadays we're using a lot of biologic treatment to treat them. And here's some of the extraintestinal manifestations. You'll see that there's a lot of overlap with ulcerative colitis, like ankylosing spondylitis, erythema nodosum, pyoderma gangrenosum, arthritis, uveitis, liver disease. The only one that's not really on here is that primary sclerosing cholangitis. And so again, we have some compare and contrast. If I was going to put my money into anything Crohn's or ulcerative colitis, I would definitely be able to compare and contrast the two. Tests just love to compare and contrast these two. Okay, so go ahead and look at this chart. IBS. So IBS is a chronic disease caused by inflammation of the bowel wall, and it can vary from constipation-based to diarrhea-based to a mixed bag. And so we often see it in women, younger women with a history of alternating constipation or diarrhea, one or both. And they often get abdominal discomfort, which is relieved with bowel movements. And to diagnose them, it's clinical diagnosis and a diagnosis of exclusion based on the Rome criteria. So the Rome 4 criteria for this, we're going to see recurrent abdominal pain on average 1 day per week at least over the previous 3 months, associated with 2 or more of the following. So it's going to be related to defecation. It's going to be onset and a change in the frequency of stool and the appearance of stool. And this has to happen over the previous 6 months or duration of 6 months. As far as treatment, we usually figure out which is the predominant symptom, constipation or diarrhea, and we treat those symptoms accordingly. There's several medications out there that are targeting those specific symptoms. All right, continued. So GI syndrome, again, caused by abdominal pain, altered bowel habits. So clinically, we'll look for a younger female patient that has kind of this longer term picture. They shouldn't have any grossly bloody stool, shouldn't wake them up at night. And again, it can be predominant constipation or diarrhea or mixed. And really, what we do initially is dietary modification and inclusion of fiber in the diet. And we also include this low FODMAP diet, which reduces the foods in the diet that are hard to break down. And we also like to have patients do like a food diary, keep track of what foods tend to precipitate the problem. And we encourage physical activity. All right, now moving on to some of the adjunctive pharmacologic therapy. Again, we're going to go based on what the predominant symptom is. If it's constipation related, we might try some osmotic laxatives. We might do some Miralax or things like that. And then eventually we'll move on down the line to something like linaclotide, which is Linzess. For diarrhea, we often start with loperamide, which is just the over-the-counter Imodium. Then we move on to things like bile acid sequestrants or serotonin 3 receptor antagonists. There's also newer medications out there that I doubt they'll test you on, like Viberzy. And a lot of times we'll also do Bentyl or dicyclomine on a scheduled basis to calm down the gut. For the abdominal pain, again, we can give the antispasmodic agents like Bentyl or dicyclomine. And then there is some cross-reactivity between behavioral health issues, depression and things, and IBS. And I haven't seen them use antibiotics very often, but it says that they can be used. Now on to ischemic colitis. We don't talk about this too much, but essentially what ischemic colitis is meaning is that we don't have good blood flow to the gut. So it's most commonly caused by inadequate blood flow through the mesenteric vessels for any specific reason. It can usually present in a patient with a history of atherosclerotic disease. They already have narrowing of the vessels. They'll get acute onset of crampy abdominal pain. It's usually out of proportion to the exam. CT will show bowel wall edema, so some swelling in there, and most cases resolve with supportive care. But if we have acute blockage like mesenteric ischemia, then we're going to need to give anticoagulation. So a lot of times for the ischemic colitis, it's usually because the patient is sick, they have heart failure, they have sepsis, and the blood's being shunted to other areas. We often see that the problem happens in these watershed areas, which is usually here and down here. Let's see. So moving on to mesenteric ischemia. So mesenteric ischemia is usually a clot or blockage. It's most often caused by an embolus from like an AFib. And the pain is, again, out of proportion to the exam. And lactic acidosis can come from it. And initially, we'll want to do a CTA if they're able to tolerate it, which will show us where the blockage is. And the gold standard is going to be angiography. All right, so here we have a picture of a CT. It's showing that thickened bowel wall and some gas within the bowel wall. And then what essentially happens is the blood flow stops to the wall and they get ischemic bowel, so it starts necrosing and dying. And when that happens, the patient can die because of the sepsis that it causes. And here are the different types of occlusions. Arterial occlusions, most often caused by an embolus, like from an AFib or other heart disease or things. Venous thrombosis, not as often. We usually see that in hypercoagulable states. And then the non-occlusive ischemia are going to be things like heart failure, more like the ischemic colitis we saw up here. All right, so large bowel obstructions, not very common. I've never seen one in the real world, but in clinical world, we need to know about it. So the most common cause of a large bowel obstruction is going to be colorectal cancer, as opposed to a small bowel obstruction, which are adhesions from surgery. Sigmoid colon is the most common area that we get large bowel obstructions. Basically, we're going to see a patient with abdominal distension, a little bit of pain. We might get some altered bowel tones when we listen on auscultation. And an abdominal x-ray is going to show us that distension and the presence of haustra. So we'll see that it's colon rather than small bowel. And we tend to, decompress, and sometimes the patients need surgery. Polyps. So colon polyps, we need to know about them. They're very common. Lots of patients have them. The main concern here is the polyps that have malignant potential, which can transform into cancer. We're going to look at the size of the polyps, the type of polyps that they are, and how many we have. Then the distal colon, we see them most often, and they're commonly benign. Proximal colon are more likely to be cancerous, and we're looking for those adenomatous polyps. So we have the villus adenomas being the worst, the most malignant potential. Again, they have the word villus. It sounds like villainous or bad, a villain. So those have increased malignant potential. We need to be more vigilant when we find these, and do more often surveillance colonoscopies. Usually, if we have a villus adenoma, it will be every 3 years. If we have just a regular adenomatous polyp, to a tubular adenoma or things like that, it'll be more of a 5-year follow-up, depending on the size, number, and type. And then most commonly, it will cause painless rectal bleeding, especially in the pediatric population, which I didn't know. And once identified, we'll do follow-up colonoscopies. Okay. All right, FAP. FAP is one of those things that I've never seen in clinic, but we have to know that it exists. So we'll see hundreds, blankets of polyps within the colon, and they are often adenomatous polyps because it is familial adenomatous polyposis. And the mean age of polyp development is 15 years. So they're developing them as kids, and 100% of them will have cancer, usually by the age of 40. So we need to find these early. We usually screen in first degree relatives, genetic screening, as well as having colonoscopies. Families should undergo yearly sigmoidoscopies beginning at the age of 12. And a lot of times these have to have complete colectomies to reduce the risk of cancer. Okay, remember that gene is the APC gene. They often test on that as well. And there are other types of familial syndromes of polyposis. And we have the Lynch syndrome and other things that we should be familiar with, but I've never seen them test it really in depth. All right, on to toxic megacolon. We've already mentioned it when we mentioned ulcerative colitis, because ulcerative colitis can cause toxic megacolon. When we think of toxic megacolon, it is in fact toxic. So patients do look very toxic when they have this. It's most commonly caused by IBD. It can also be caused by C. diff. So we have a history of UC is the most common thing we'll see. And the patients will be toxic. They will have tachycardia, and they'll be febrile, and they'll have a high white cell count and things like that. Abdominal x-ray is going to show the colon dilation, and has to be greater than 6 centimeters. That's hard and fast. You need to know that number. Management is going to be to treat the patient symptomatically. We're going to give them lots of IV fluids, antibiotics, steroids, and they'll need emergent surgery consult. And then here, it's a clinical diagnosis, although we do use imaging to help back that up. And you're going to look for signs of toxicity. So the fever, the heart rate, the anemia, the white blood cell count, plus one of these following things. And then again, we need to consult the surgeon and identify the underlying condition. All right, we've done the colon stuff. Let's move on to esophageal. So infectious esophagitis, most often caused by Candida, which is yeast within the esophagus. If we have yeast in the esophagus, it's not normal, okay? Sometimes we'll have some yeast in the mouth, especially if we use like inhalers that have steroids in them, or we just got placed on antibiotics. But if we see Candida in the esophagus, we need to look for an immunocompromised state like HIV or diabetes or things like that. A lot of times these patients will have some pain with swallowing. And when we do the endoscopy, which is the test of choice, EGD, we will look for these yellow-white plaques, kind of patchiness along the esophagus, and we treat with fluconazole. Other infectious etiologies can cause esophagitis like HSV, but with herpes, we'll see shallow ulcers, and we treat that with acyclovir. And CMV or cytomegalovirus, not as common, also found in immunocompromised patients. They'll have deep ulcers, and we'll treat that with ganciclovir. Okay. We can also have medication-induced esophagitis. So medication-induced esophagitis is going to be caused most often by NSAIDs. It can also be caused by the bisphosphonates we use for patients with osteoporosis, because they're pretty big pills. And it often happens after patients take it, they don't drink enough water, they lay down right after they take it and it gets stuck. And we'll usually see an ulcer in a linear path or like a specific area of ulceration after taking a pill. And again, these are some of the most common causes. So antibiotics, bisphosphonates, iron, and potassium, and NSAIDs. Here's that picture of the esophageal candidiasis. Again, we see it most often in HIV patients or patients that are immunocompromised, like diabetes. It's caused by Candida, and we see it often with CD4 count less than 200. Eosinophilic esophagitis is an allergic type esophagitis where eosinophilic infiltration happens in the esophagus. It can also happen in the abdomen, in the stomach. And asthma symptoms, atopy, and other things are related to it. And this usually not very responsive to antacids. These patients get GERD. And we'll often do an EGD, which shows this ring formation in here, which is pathognomonic. We usually treat them with steroids, usually inhaled steroids that we have the patient swallow. Sometimes we have to resort to oral steroids. GERD, super, super common. Reflux, heartburn, most commonly caused by that lower esophageal sphincter, which is not functioning correctly, not closing off the stomach. So we get backsplash of acid up and into the esophagus, which burns. They'll often have associated nocturnal coughs, burning in that retrosternal area, especially after eating or laying down after eating. If they're mild, less than 2 episodes a week or every 2 weeks, or after they just eat certain things, we can try H2 blockers. But if they're any more than that, we want to try them on PPIs. Management, we also want to tell them all the supportive care things like losing weight, elevating the head of the bed, avoiding certain foods, and not eating late at night. Okay. All right, so moving on to Barrett's esophagus. So Barrett's esophagus is going to be inflammation and metaplasia of the cells. So basically, when in a setting of chronic GERD, a patient that has chronic GERD, basically where the esophagus meets the stomach cells are perfect. They're the perfect type of cell to withstand that acidic environment, but the esophagus isn't. And so the way that the body tries to compensate for all of that backsplash of acid is to try to change the cells from a squamous epithelium to a columnar epithelium. And when this transformation happens, that is a precursor for potentially an adenocarcinoma. And so the management for this, well, we would diagnose it by doing an upper endoscopy and getting biopsies. Sometimes we can even see it with our eyes. We can see the change there of the cells, like a little finger-like projections in the distal esophagus. We'll get biopsies, which will confirm this. And then the patient needs to be on PPIs for long term because they have an increased risk of developing adenocarcinoma in the esophagus. There's different grades of dysplasia. Some of them have no dysplasia, just metaplasia, and this would be just an surveillance endoscopy every 3 to 5 years. If we have low-grade dysplasia, we're going to need to do annual upper endoscopies, and they'll probably have to include some radiofrequency ablation. And then high-grade dysplasia, they're going to need to do RFA. Mallory-Weiss syndrome. Mallory-Weiss syndrome is essentially little tiny cuts within the distal esophagus caused by retching or forceful vomiting. So we'll see incomplete longitudinal tears in the esophageal mucosa and proximal stomach. The history is going to be either an alcoholic or a frat brother that has binging, and they have retching or forceful vomiting, and they will often have a little bit of bright red blood or hematemesis. And the diagnostic procedure of choice is going to be an upper endoscopy. And most of these are going to resolve on their own without needing any type of treatment. But management would generally be supportive care, which would include placing the patient on PPI to help it calm down and to help those little cuts heal. Occasionally, when they go in to do the endoscopic treatment, they'll treat the active bleed, but most of the time it's not needed. And acid suppression, we can also add on to that. Achalasia is a motility disorder. So we often see dysphagia to both solids and liquids, and we'll diagnose it. Typically, we diagnose it initially. What we'll do is an endoscopy or an EGD, and that's to rule out cancer and also just take a look. But the diagnostic study it says in here would be a barium swallow, although I'm not 100% that the barium swallow is the first or initial test, but it can show that classic bird speaking. The gold standard, however, which we don't do that often initially or ever, is an esophageal manometry, and that's going to show the pressure, increased pressure in the lower esophageal sphincter area. And the treatment for this is usually initially a pneumatic dilation where we go in and we put a little balloon in here which dilates. We can also do Botox injections, and end line would be Heller myotomy or a POEM, which helps release some of the musculature down here at the bottom and helps renew the passage between the esophagus and the stomach. These don't often treat very well with medications. Usually they need those procedures to get better. Esophageal spasm or diffuse esophageal spasm, or DES, is another motility disorder of the esophagus, often characterized by chest pain and some dysphagia. Sometimes it can be precipitated by eating hot or cold liquids or stress. And basically what we have is this corkscrew esophagus. So we see lots of spasming at different levels of the esophagus. And the diagnosis of this, well, this is a barium swallow. So we'll often do that initially, but the definitive diagnosis is made via esophageal manometry. And we often treat these initially. The first thing we treat it with is usually a PPI to see if that resolves it, because a lot of times it's the GERD that's making the DES happen. But if the GERD is not improved, or the DES is not improved with PPIs, then we move on to these calcium channel blockers next. All right, esophageal strictures. So there are different types of strictures. We have esophageal webs, which are these little, they look like little cobwebs that thin out they're little thin membranes that kind of take up a little corner of the lumen of the esophagus. We can also get what's called Plummer-Vinson, which are esophageal webs plus dysphagia plus iron deficiency anemia. So you'll look for the spooning of the nails and glossitis and other things along with it. And then Schottky rings, which are diaphragm-like, so they're circumferential because they're rings that block some of the lumen of the esophagus. Presentation, because it's an obstructive process, we usually see solid food dysphagia before we see liquid dysphagia. And then the diagnostic study of choice, it says here that barium swallows, although I often see EGDs done first. And along with the EGD, they can do these endoscopic dilations, usually with a balloon. But there's multiple ways to diagnose this, including a combination of the following that are here. Varices. So varices are a big problem, especially in cirrhotic patients. We most commonly see it in the setting of portal hypertension, which is usually caused by cirrhosis of some type, either alcoholic cirrhosis or hepatitis-induced cirrhosis of the liver. So we're looking for that chronic liver disease, alcoholism. A diagnostic study, an upper endoscopy is going to reveal these. They're basically like varicose veins or hemorrhoids kind of in the vessels surrounding the esophagus, and we'll see them dilated. Sometimes we'll see them bleeding. We want to hopefully prevent them from bleeding. If they are acutely bleeding, we're going to provide hemodynamic support and resuscitation, in addition to octreotide, vasopressin, and we might even have to use this Blakemore tube, which is basically a tamponade of the esophagus until we can get in there with an endoscopy and ligate or cauterize the bleed. Chronic varices, we can place the patients on beta blockers to help reduce some of the pressure within that system. And then we will do EGDs on a scheduled basis to go in and try to ligate or rubber band these before they bleed. But they can be associated with very massive GI bleeding and even death. All right, moving on. Let's do some food allergies and food sensitivities. All right, let's move on to food allergies and food sensitivities. Let's start off with lactose intolerance. So I think a lot of us might or might not think we have lactose intolerance, but symptoms include this bloating, cramping, gassiness, diarrhea, kind of rumbling of the stomach, or even vomiting after consuming lactose. And the test of choice really to diagnose it, you can either exclude lactose and see if that resolves the symptoms, or you can do what's called a hydrogen breath test that would give us the definitive diagnosis. And treatment really focuses on avoiding dairy products. We can also use lactase supplements, which are pills that help us break down the lactose containing products. Gastric disorders. Okay, so let's talk about gastritis. Gastritis it can be caused by multifactorial issues. So it can be caused by H. pylori, which is the most common cause of gastritis. It can be caused by inflammation due to NSAIDs or alcohol, or it can be autoimmune. And we think of that as gastritis as pernicious anemia. So we'll see a positive Schilling test, decrease intrinsic factor, and we'll see peroxidase antibodies on an exam. And we're going to look for these things. So H. pylori, we'll probably get a biopsy when we do the endoscopy, which will show us, or maybe we will suspect it before we do the endoscopy, and we'll get a urea breath test or a fecal antigen that will show us that H. pylori is present. If we see H. pylori, we need to treat it with either triple or quadruple therapy. As far as NSAIDs and alcohol, we need to decrease those. So take the patient off NSAIDs, put them on maybe Tylenol, and tell the patient to cut down on alcohol. The most common presenting symptom is this dyspepsia, unwellness, kind of bloating, belching, unwellness in the epigastric area often, as well as abdominal pain. So the diagnostic studies, so endoscopy with biopsies is going to be the gold standard, and we often have to resort to that because it presents very similarly to peptic ulcer disease and GERD. And so to get the definitive diagnosis, we have to do that endoscopy. Here's some of the different causes and the diagnosis and treatment. Don't forget, if we have the pernicious anemia, we need to give B12. Peptic ulcer disease. So peptic ulcer disease is an umbrella term for both gastric ulcers and duodenal ulcers. So there's two different types, gastric, duodenal, but they're both called peptic ulcers. Most commonly, it's caused by H. pylori infection. Can also be precipitated by NSAID use. These patients often present with a gnawing or hunger type pain within the epigastric region. And textbook-wise, duodenal ulcers the pain tends to be alleviated right after they eat. Because the small intestine is being blocked off as food is being churned in the stomach. And so they get relief of some of the pain. And then the pain starts once a few hours have passed after they eat, and then the food starts going through the small intestine. Gastric ulcers tend to be painful right after eating the food because the food's going directly into the stomach where the ulcer is located. As far as diagnostic studies, we want to rule out H. pylori as the cause. We can do, usually urea breath test is considered first line, or a fecal antigen test. If it is H. pylori induced peptic ulcer disease, we need to give at least triple therapy. In some areas that are resistant, we do quadruple therapy. And We also need to keep in mind that complications from peptic ulcer disease can also change the presentation. So it is the most common cause of upper GI bleeding. And so we need to be mindful of that complications can include that bleeding, which we might see as a coffee ground emesis or melena if it makes its way all the way to the stool. As it can also cause gastric outlet obstruction from the inflammation, and it can also cause perforation. H. pylori specifically, so we know that H. pylori can cause gastritis, it can cause ulcers, and it can cause cancer. It's the most common cause of gastric carcinomas. As far as diagnosis, again, we have several options, but we often do the H. pylori breath test because it has the best sensitivity and specificity combined. Serology, we can also do as a blood test. It's not as good, and we can't use it to see if it's eradicated because it will always be positive once it's positive. Fecal antigen is also pretty good. I tend to see them use the fecal antigen more often when we're testing to make sure that the infection has been eradicated. And traditionally, we've always used a triple therapy, including a PPI and some antibiotics. Nowadays, there's some resistance in certain areas, so we've bumped it up to quadruple therapy, but you need to look at your endemic area, wherever you're located. So there's the quadruple therapy. All right, pyloric stenosis. Pyloric stenosis is a pediatric illness. Okay, so we're going to see it in infants, usually very, very young infants, 2 to 6 weeks old. They're going to have this non-bilious projectile vomiting. We're talking about projectile across the room. It's usually after feeding, and they get full pretty quick, and they get this unwell. They have this projectile vomiting, and then they're ravenously hungry again. And on exam, we'll feel a right upper quadrant olive-like mass, which is the hypertrophied pylorus that we're feeling. And because they're vomiting so much, they're vomiting up all the acid in here. They have decreased acid within the stomach, so they'll get a metabolic alkalosis as a result. And testing of choice, we have two really: ultrasound, which shows us that target sign, or an upper GI series, which shows us the string sign. They're both used. And then as far as management, we're going to do surgical intervention where we basically go in and we remove some of this hypertrophied pylorus to allow the blockage to be fixed. And here's those two signs. So this is the thickened, elongated pylorus and the target sign on ultrasound. I've seen more often nowadays we use ultrasound. It's very accessible, no radiation. And so that's what I see them use most often. Again, treatment is a pyloromyotomy, which is removing some of the pylorus, and then also supportive care for the electrolyte imbalances. All right, moving on to hepatic disorders. So acute hepatitis. I think students have a lot of trouble with hepatitis, but really let's see if we can break it down to what we actually need to know. So acute hepatitis has multiple different forms. We need to be familiar with all of them. We have hepatitis A, B, C, D, E, and those are the ones that we see here. So hepatitis A is a fecal oral. We can also get it from shellfish. And they can also be asymptomatic, but it's usually in an acute setting. So fecal oral, acute setting of jaundice and kind of unwellness, diarrhea, vomiting, and it's self-limited. We usually just do supportive care. Hepatitis B, I think, is the hardest one, so we'll come back to that one. Hep C, we'll see it often in IV drug abusers. It can progress to that chronic state and cirrhosis, and it can lead to hepatocellular carcinoma, and there is a carrier state for this. Hepatitis D is dependent on hepatitis B. And I usually think of it as bud, B-U-D. They're buddies, right? B and D are buddies. So they have to be, B has to be present for D to be present as well. Hepatitis E is also fecal oral. I think of A&E, like the channel on TV. They're both fecal oral, so the vowels hit your bowels, okay? And then there is a vaccine available for hepatitis A and B. So we usually do Hep A vaccines, not routinely, but it is now routine in the peds population in the schedule of vaccines. But we do it like for travelers and things. And then Hep B we use especially in healthcare settings. Okay. Autoimmune hepatitis can happen. Look for that in young females. And then alcoholic hepatitis, look for that AST to ALT 2-to-1 ratio. All right, now we're going to go through them individually. So Hep A, look for that acute onset of symptoms nausea, vomiting, diarrhea, fever, jaundice, abdominal pain. It is fecal oral transmission. Diagnosis is going to be made via serologies. So we're going to look for that Hep A IgM. IgM is, I think of is immediate, IgM immediate. So it's going to be positive in the acute infection. And then IgG is positive after we've overcome the infection or we've been immunized. Right. Hep B. So we said we were going to come back to Hep B, and I think that's important. So Hep B. So the surface antigen is going to be the first thing that we see. So that we're going to use it to screen for and detect the acute diagnosis. It's going to be the earliest indicator of Hep B. And there's usually like a little chart that we see that shows like the little waveforms of hepatitis. I think that's probably the best chart to study for this. But basically, we're going to identify those that have the disease with Hep surface antigen. Then the surface antibody is what we get when we have eradicated the disease. So it's going to tell us whether someone had it previously and if the patient is immune to further hepatitis B. Okay. It also determines the need for vaccination. It can develop from successful vaccination. So if we see only the anti-HBs, then we know that the patient was successfully vaccinated. Then we have the cores, so the IgM and IgGs, the antigen antibodies, and those are going to help you detect acute versus chronic. So the IgM we're going to see earlier, IgG we're going to see later in the process. Hep B antigen, the envelopes are going to show infectivity. And so if you're having trouble with this, I think the best thing to do would be to go through my lecture on hepatitis B. I have a lecture specifically designed to help you work through hepatitis B, which I will link. Hep C. Hep C, the acute process is usually asymptomatic. 80% of these patients, though, go on to have chronic infection, and of those, 20% develop cirrhosis. The good thing about hepatitis C is that we can treat it nowadays. It's very expensive, the treatment and stuff, but we can treat it. So we are seeing lower and lower rates of hepatitis C. Cirrhosis. So cirrhosis can be caused by lots of things. Here in the United States, number one cause of cirrhosis is going to be alcohol, and then hepatitis, and then autoimmune. So on physical exam, we're going to see lots of manifestations, especially from portal hypertension. We can also see problems with the lack of filtration of the liver. We also see problems because it's not filtering properly. We're not getting estrogen out of the system. So we'll see signs of hyperestrogenism including gynecomastia, pulmonary erythema, and delayed clotting. Well, that's not really related to the increased estrogen, but we'll see delayed clotting. Hepatic encephalopathy, we'll get that classic asterixis and confusion, and portal hypertension, which causes lots of things, including esophageal varices, hemorrhoids, caput medusa, and splenomegaly, ascites. Management for the hepatic encephalopathy is going to be lactulose and a low protein and low sodium diet for the ascites. We're adding increased risk for hepatocellular carcinoma when we have cirrhosis, so we have to screen for it using AFP and ultrasounds every 6 months. Let's talk about alcoholic cirrhosis. So alcoholic cirrhosis is an increased, chronic alcohol consumption. They say it can take as little as 4 drinks a day for a period of time. It's the most common form of cirrhosis in the U.S. Initially, what we have is like a fatty liver or a inflamed liver. We get deposits of fat within the liver, and then it starts to progress onto a fibrotic liver and then to a nodular liver where the liver shrinks down and becomes scarred. And once it moves on to those later phases, it is irreversible. And here's some of the chronic things that we see. So we see hepatomegaly initially, and then cirrhosis, it shrinks down, and we see ascites, which is fluid that happens within the abdominal cavity due to increased hydrostatic pressure from the portal hypertension and decreased oncotic pressure from the decreased albumin and proteins within the blood. We'll see this caput medusa, which is increased vasculature around the umbilicus most often, and it happens because the veins become dilated due to the portal hypertension. We can see gynecomastia, which is an impaired breakdown of estrogen, so it's increased breast tissue, especially in male patients. We might see scleral icterus related to jaundice, which is basically jaundice of the eyes, so increased bilirubin. Due to dysfunction in the metabolism. Pulmonary erythema is from buildup of estrogen as well, and so is spider nevi angiomas. Ecchymosis we'll see because of defective coagulation. We see that because there's some sequestration of the spleen and decreased production in the liver. And then these few other little things, and there's the asterixis. They might also have this fetor hepaticus, which is a death breath that you get from having hepatic encephalopathy. All right, moving on to hernias. So hernias are usually a surgical specialty kind of thing, but we do cover them in GI. So as far as hernias are concerned, let's talk about inguinal hernias first. There's two types of inguinal hernias. We have the indirect and the direct. So indirect are problems usually as patients are born, so more genetic or more congenital problems. And indirect have basically the herniation goes into the canal in the inguinal into the inguinal ring and into the scrotum, whereas direct protrude through a defect in Hesselbeck's triangle, so those come out through the abdominal wall themselves instead. And this is usually acquired, so patients tend to get it later on in life. It also has a bimodal distribution, so we see it a lot in little kids and a lot in older people. And if the hernia is non-reducible or it cannot be pushed back in, this is an emergent surgical consultation because of the risk of strangulation. All right. So we need to know the difference between reducible, incarcerated, and strangulated. So reducible means I can push it back in and it's easy to push back in and out. Incarcerated means it's stuck on the outside. It cannot be reduced, but it doesn't imply any type of strangulation of the vessels. And strangulated is due to impaired blood flow to the bowel, which can cause necrosis and other things. And here's another picture of that inguinal triangle. It's looking at Hesselbeck's triangle and other things. Okay, so it's anatomy. This is a good one to separate out all the different types of hernias because there's more than just inguinal hernias. There's also femoral hernias, which are more common in women, or they are the most common hernia in women, and they are more prone to incarceration and strangulation. There's also incisional hernias, umbilical hernias. There's all sorts of ones. So I definitely take a look at this little chart here. All right, on to infectious diarrhea. So food poisoning. Everyone's heard of these. We got to know the different bugs, and the incubation period is very, very important. So let's see, what do they have? They have invasive and non-invasive broken down this way. I think that's probably the easiest way to kind of look at it. So let's look at the invasives first. The invasives are the ones that are going to cause usually a bloody diarrhea. And so salmonella is one of them. We often see it from contaminated food like eggs or poultry. And we see it in the ninja turtles, right? The lizards and turtles and baby chicks. Incubation's 8 to 72 hours. They'll get fever, abdominal pain, myalgia, and they have a risk of sepsis in the young, old, and immunocompromised. Shigella, 1 to 3 day incubation period, contaminated food, person to person, or fecal oral. And they have fever, myalgias, headaches, diarrhea. It's really also common in younger kids. Campylobacter, 1 to 7 days, and contaminated water, food, poultry, eggs, animal, pets, low-grade fever, abdominal pain, and then common in children and young adults. And remember, the Campylobacter also has to do with Guillain-Barré, right? Yersinia enterocolitis. So Yersinia is going to be contaminated water, food, milk, fecal, oral, person to person, and it may mimic appendicitis. C. diff, look for recent antibiotic use. Penicillins and clindamycins are most common culprits. They'll have fever, abdominal pain, foul-smelling diarrhea. Amoebic dysentery, so look for contaminated food, water source, poor sanitation, abrupt onset, nausea, vomiting, diarrhea. Enterohemorrhagic E. coli, or O157H7, is going to be the contaminated food or water or undercooked meats. I think of Jack in the Box, and these are the ones that cause a hemolytic uremic syndrome in the kiddos. They'll also have grossly bloody diarrhea. This one I see tested quite a bit, so definitely know about it. Non-invasive gastroenteritis. So viral is going to be by far the most common thing we see. Things like norovirus or norwalk or rotavirus are the most common types. Look for the signs or symptoms or like the settings of those. So close quarters, cruise ships for norwalk, daycare kiddos for rotavirus, self-limited. Giardia is usually longer course, longer away from when you're exposed. Contaminated food or water. I mostly see it in stream water, consuming stream water. Backpackers or campers, they'll get this really like foul smelling, greasy stool, and a lot of bloating, and it's the most common intestinal parasite in the US. Staph has the shortest incubation period that I've seen. We'll see it like often in egg salad, potato salad, picnics, and things like that. And they usually have more nausea and vomiting, but they can have diarrhea as well. It's self-limited. Bacillus cereus is previously cooked meats, rice, vegetables. Then Clostridium. Clostridium is the previously cooked meats as well. It has the next fastest incubation period. Cramps, diarrhea. Vibrio, remember that one is the one that's caused by raw or undercooked seafood. It can also be fecal oral contaminated water sources, and they're going to have explosive rice water diarrhea, and we're going to have to worry about their hydration status. Whew, that was a lot. All right, traveler's diarrhea. Traveler's diarrhea is caused by ETEC, which is the E. coli, that it's enterotoxigenic but not enteroinvasive. And most common recent travel history: abrupt onset of watery diarrhea, nausea, abdominal cramping. We want to use a lot of rehydration. We can give Cipro or zithromycin. And let's see. C. diff. So we talked about that a little bit. C. diff is most caused by recent antibiotic use. Clindamycin is most common, followed by beta-lactams. Frequent watery stools, very, very foul smelling. We can do the nucleic acid amplification test, or NAT, to diagnose it. And in adults, we can give them oral vancomycin or oral fidaxomicin. Do not give IV. IV won't help. For fulminant, we'll also do that, along with parenteral metronidazole. And for kiddos, if it's not too severe, we do the oral vanc most often. Let's see. If they have more than 2 C. diff infections or recurrence, or it never goes away, we can consider doing a fecal transplant. Okay. All right, more on C. diff. C. diff can also cause what we call pseudomembranous colitis, where you get these little membranes within the lining of the gut, and we'll look for that on endoscopy, colonoscopy. All right. So ingestion of toxic substances or foreign bodies. You need to be familiar with this, especially for like an ER rotation. But basically, it's telling you what the poison is, like let's say Tylenol, and what the antidote is. You should be familiar with these. And I'm not going to go through each one by one, but you should kind of look at this chart and be familiar with it, especially for your PANCE exam. As far as foreign body management, if it's sharp foreign body, it needs to be removed. Okay. Blunt foreign bodies, as long as they're not acid, button batteries or magnets, and it makes its way past the stomach, you're usually pretty good, and just follow up with repeat radiography. Coins, if they can make their way past the stomach, usually good as well. If they're stuck in the esophagus, need to be removed. Button batteries are always an emergency. You got to get them out. Magnets as well. And then packets or druggies, you have to be really careful with those, because if they rupture, we can have a big problem. Okay. Metabolic disorders. So G6PD, I am not going to cover in this lecture. Most often this is covered in the hematology section, so be sure to look out for that, as well as Paget's. I don't usually cover that here. PKU I do. It's usually pediatric stuff. So most commonly caused by autosomal recessive genetic mutation, which we test for newborn screening. They'll have, if they make it past the newborn screening and they're not diagnosed, we'll often see a very pale looking patient with a musty odor and growth retardation or mental delay, developmental delay. They'll have decreased phenylalanine hydroxylase, and essentially it decreases in this cycle a tyrosine. And we want to avoid the artificial sugars and things like this. There's a special diet that they follow right here. Vitamins. All right, we're going to the vitamins now. So vitamin D, we get it from sunlight. So a lot of times, a lot of us are vitamin D deficient because we are inside in fluorescent lighting by our computer all day, every day. But vitamin D, we see it often in elderly, low sunlight, and the deficiency can lead to rickets in kiddos and osteomalacia in adults. Vitamin D also, we have vitamin D fortified things like milk and stuff that have that in them. Vitamin D is needed for calcium, so that's why we see bony involvement when we have vitamin D deficiency. All right, neoplasms. So let's see. We're going to start with esophageal cancer. We've kind of mentioned it a little bit already, but let's go through it quickly. So squamous cell carcinoma is most commonly caused by smoking and alcohol, more often in African American individuals. Adenocarcinoma, most often caused by Barrett's esophagus, caused by GERD. We're going to look for older man. Weight loss dysphagia, mostly solid food dysphagia that can progress to both solids and liquids, like an obstructive process. We're going to do an endoscopy with biopsy, and we need to do that if we have a suspicion for cancer. There we go. Gastric carcinoma. So adenocarcinoma is the most common type of gastric cancer. H. pylori is the most common history that we'll see with it, as well as it takes a while for a gastric cancer to kind of show itself. One other thing you might look for is this periumbilical node. It's also called a Sister Mary Joseph node or a Virchow's node that you can see in the left supraclavicular area. Look for that as well. All right, nutritional and vitamin disorders. So we covered vitamin D already. Now we're going to go on to the other ones. A, D, E, K are going to be our fat-soluble vitamins. So A, D, E, K. So A is one of them. So A, we think about eye stuff, eye problems, right? So night vision, dry skin, growth retardation, blind spots. And so we get supplement. If it's missing, we supplement it. So we give them vitamin A if they're missing vitamin A. The fat soluble vitamins can build up as well in the fat, so we can get hypervitaminosis states from fat soluble vitamin over amounts, so increased amounts of it. So hypervitaminosis we can get, and so we'll look for these things here. Vitamin B1. So B1 is not fat soluble. All the Bs are not. So B1 is a thiamine deficiency. We see it a lot in alcoholics and malnutrition. And we're going to look for the classic Wernicke-Korsakoff. So Wernicke-Korsakoff causes encephalopathy, which causes disorientation and indifference and attentiveness. It can have nystagmus and decreased gait disturbance or increased gait disturbances like ataxia. And the theoretical worsening of Wernicke-Korsakoff is if we give thiamine after the glucose. So we want to give both. So a thiamine deficiency can also be called beriberi. Okay. And we look for these different findings here. So neuropsychiatric beriberi is also called Wernicke's encephalopathy. And this causes those signs and symptoms of hallucinations, aggressive behavior, confusion, nystagmus, amnesia, ataxia, stuff like that. Dry beriberi usually causes like neurologic stuff like hyporeflexia, seizures, and pain in the extremities, weakness. Wet beriberi is more like heart failure. So we see tachycardia, respiratory distress, edema, and right ventricular dysfunction. They also have some GI symptoms, including nausea, emesis, constipation. B2, we don't see it very often, but is basically causes some problems with the mouth, so chelosis and things like that. B3, you need to think of, there's more than the 3Ds, but I guess you can think of the 3Ds to help you. So this is a niacin deficiency, and it causes what we call pellagra. Pellagra is a niacin deficiency. We see it often in corn-based diets in Asian countries and things. And the 3Ds are dermatitis, diarrhea, dementia, and then it can also cause death. Okay. So there we go. Vitamin B6, I don't see it tested very often, so I'm not going to cover it. It can cause some neuropathy. We want to give it, remember when we have the isoniazid for the RIPE therapy, we want to give B6 along with it. B12. So B12 and folate deficiencies I see most often covered in the hematology module. So I'm not going to test on it in my GA module, but we need to be familiar with B12 deficiencies. B12, because it has the numbers like the 12 cranial nerves, it can cause neurologic issues, whereas folate deficiency doesn't typically cause any neurologic manifestations. But we need to replace the B12. Vitamin C is, I think, of pirates because it causes scurvy when we have a deficiency of vitamin C. And we have what we call the 4 H's. So hemorrhage, like petechia and bleeding gums, hyperkeratosis, so rough skin, losing their teeth, hypochondriasis, and the hepatologic abnormalities. Hematologic abnormalities. And they're often found, like vitamin C, we see that in like, oranges and things like that, right? Vitamin K deficiency, so we'll see increased bleeding and increased PTT with a normal bleeding time. So we know vitamin K is involved in all of these different types of factors, so look for increased bleeding time. Okay, just take a look at this. These are some of the common kind of buzzwordy things that we see with the different vitamin deficiencies. Pancreatic disorders. So acute pancreatitis, most we'll see it most often caused by gallstones and then alcohol. And they usually have an epigastric pain that radiates to the back along with nausea and vomiting. Essentially, like they have a burning on the inside. So it's very, very painful, and we treat it kind of like a burn. So we'll have in really bad presentations where we have the hemorrhagic pancreatitis, we'll see these signs. We'll see gray turners, which is ecchymosis of the flanks, and colon, which is ecchymosis of the umbilical area. And we'll look for the elevated lipase, which is better, but we can look at both amylase and lipase. Diagnostic studies, it says here that ultrasound is first, but I've always seen CT being used. And then we want to keep them NPO, give them lots and lots of IV fluids, and then use Ranson's criteria to predict the severity. And I don't see that they've included Ranson's criteria here, but you should definitely know the C-Hobbs, the mnemonic, and know the different components. Oh no, here we go. We're good. We have it here. So we'll look for elevated lipase, epigastric pain, nausea, vomiting. It's basically autodigestion of pancreatic enzymes getting kind of released and then autodigesting the pancreas and inflaming it. Here's your Ranson's criteria. So this is the two different criteria. So we want to look at these things at admission and these things after admission. And we'll come up with a score. It basically gives us a mortality rate, and it can be fatal, acute pancreatitis. A pancreatic pseudocyst we can see after acute pancreatitis. It's a complication of that. And if we see one, we want to kind of figure out whether it's early or late, and we might need to drain it and take a look at that. So that one of the things that I see often is like the different causes of acute pancreatitis. It's a good pimping point, or a point that they like to ask about. So I get smashed, or get smashed is a mnemonic that you can use to remember the different causes of acute pancreatitis. Chronic pancreatitis is, a buildup over a period of time of inflammation, which causes problems with both the exocrine and the endocrine pancreatic function. So basically, we get this abdominal pain plus the pancreatic insufficiencies, not producing the enzymes that break down our food. So we'll see steatorrhea in addition to the chronic abdominal pain. Here's that colon sign. Around the umbilicus, CU, and you can see the umbilicus there. So it's ecchymosis around the umbilicus, gray turners on the flanks. Pancreatic cancer. So this one I think is pretty pathognomonic on exam questions. So it is most commonly adenocarcinoma. Patients typically have a history of smoking, which is a really one of the most important risk factors that we see. They'll have painless jaundice and weight loss with a possible palpable non-tender gallbladder. I see that most often, and that's called Cavassier sign. You can also have a migratory thrombophlebitis, which is Trousseau syndrome. And so we're going to palpate. If we see a patient with painless jaundice and a palpable gallbladder that's non-tender, think pancreatic cancer. Has a pretty bad prognosis. Small intestine. Looks like we're getting towards the end. My little bubble here is towards the bottom, so bear with me here. Small intestine disorders, appendicitis. So most commonly it's caused by a fecalith that blocks the appendix and causes inflammation to the appendix. And appendicitis we see most often in the teens, kiddos and teens, early 20s, males more than females. And it causes fever, right lower quadrant pain. It usually starts periumbilically and migrates to the right lower quadrant along with nausea, vomiting, and anorexia. There are several different signs. You need to be familiar with all of them. So you need to be familiar with the McBurney's point. You need to be familiar with the SOAS sign and obturator sign and Rovsing sign. So SOAS sign, pain on extension of the right hip. We'll often see that in a retrocecal appendix. Obturator sign, internal rotation of a flexed hip. And then Rovsing sign, pain. When you push in the left lower quadrant, pain happens in the right lower quadrant. Diagnostic studies of choice. Traditionally, they've been CT, especially in adults, but nowadays we're moving a little towards ultrasound as it's being used more often. Kiddos, I would always try to do an ultrasound first, and the management is surgical. So here's some of those signs that we were talking about. So again, we see them most often 10 to 19 year age group, more often in men than women, boys than girls. And let's see. So there's the signs and symptoms. And then here's Rothstein sign, palpate here, pain happens there. There's McBurney point, which is 2/3 the way between the ASIS and the umbilicus. And there's psoas sign, you pull the hip extended and it kind of rubs the appendix retrocecally. And then obturator can also be from a rectocecal. All right, here's some more imaging. So appendicitis is going to get tested. You're going to get tested on it. You're going to see patients with it. So ultrasounds looking for that dilated appendix. And there's another depiction of Rothstein sign, psoas sign. All right, celiac disease of the small intestine, okay? And it is an autoimmune disorder related to lots and lots of symptoms, okay? So it can have a variation of symptoms from diarrhea, steatorrhea, flatulence, weight loss, bloating, you name it. Sometimes they even have constipation, distension. We're going to look for two things, really. The best is going to be the TTG-IgA, and the EMA as well can be positive. These are the serologies that we're going to do for this. But the best test, the most accurate, is going to be the biopsy of the small bowel. Okay, and do that via EGD. Management is going to be a gluten-free diet. As we've talked about, it's not as easy as it sounds. So gluten-free is kind of hard because there's cross-contamination. And here are the types of foods that have gluten-containing products. And sometimes they'll have this dermatitis herpetiformis, which is like a blistery rash on the extensor surfaces of the elbows and the upper arms and knees and areas like that. But you don't need to have dermatitis herpetiformis to be diagnosed with celiac. Intussusception, pediatric illness, okay, most often caused by a tumor or Meckel's diverticulum. And they usually see it in a kiddo, like a toddler, so anywhere from 5 months to 3 years old. It's going to cause this colicky abdominal pain, which comes and goes. It's intermittent. And they'll get these like really bad where they're crying, fits of pain, drawing up of the legs and writhing, kind of rolling around, unsettledness. And then they have periods of relief where they'll be extremely exhausted. They'll just be laying there kind of almost listless. They can also have these bloody stools. We'll often see parents bring the diaper in, this currant jelly or red colored stool. Diagnosis I've seen most often done via ultrasound to look for that target sign. Okay, and it's essentially telescoping bowel. You can also you can diagnose and treat with a contrast enema or air contrast enema. That is both diagnostic and therapeutic, but often we do the ultrasound first. Okay. Small bowel obstruction, SBO. So it is more common than a large bowel obstruction, most commonly caused by adhesions from prior abdominal surgery. So you're going to look for that in the history. They can have bilious vomiting depending where the small bowel is obstructed. If it's past where the bile inserts or is injected into the bile. Physical exam, we're going to see a lot of distension. We're going to have abnormal bowel sounds, usually high pitched with tinkles and rushes. And diagnostic study is going to be an X-ray, plain film. We're looking for those dilated loops of small bowel with air fluid levels. That's what I see most often. And then management, depending on how bad it is, we can just decompress with the nasogastric tube. And some of these patients need surgery, especially if there is obstruction to the point where it's completely obstructed and there's necrosis of the bowel. And that is it, y'all. That was the last one. I'm kind of glad that was long. There's a lot in GI. So if this was too long for you, I hope you took it down in bite-sized pieces to digest it better, pun intended. Again, I love GI. I think it's fun, but it's just so much material. It's not hard material. It's just a lot to consume. So take it again. If you have to do it in chunks, break it down. And if you have any questions, be sure to type them down below in the comments or send me an email. I'd be happy to answer them for you. And thank you again for tuning in. I'll see you next time.